Hello, you are listening to the RxConnect podcast. This podcast is brought to you by the Pharmacy Operations Group at the American Oncology Network. We are committed to delivering operational, clinical, and financial efficiencies based on the most sustainable model, reshaping the future of community oncology practice. I'm your host, Cassandra Perkey, and I'm one of the regional clinical pharmacists with the pharmacy operations team at the American Oncology Network. To listen to the podcast and to read the transcript, please visit our website at aoncology.com. To continue on our ongoing series of podcasts on bispecific T-cell engager therapies, or bispecifics as I may refer to them, we will focus this episode on overcoming the challenges of initiating bispecifics in the hospital setting when necessary, and then how to successfully bring these patients back to the outpatient clinic to continue treatment. So joining me today is Jennifer Hare. She's the clinical nurse navigator at Genesis Cancer Center in Arkansas. Jennifer's career in oncology has evolved quite a bit over the last 20 years, starting as an infusion nurse and transitioning to research coordinator to even managing a dispensing pharmacy. So she's worn many hats. Later, she became clinical nurse manager, where she identified a critical need for a dedicated navigation program and started her role as clinical nurse navigator. Under her leadership, the navigation program at Genesis has been honored with an Operation Excellence Award by AON, which is a huge testament to her commitment to patient-centered care. So congratulations and welcome, Jennifer.
Hi, how are you doing?
I'm doing very well. We're so happy to have you. So we'll just jump right into some questions about how you manage these bispecifics at Genesis. So Jennifer, can you start by describing your involvement as clinical nurse navigator with the local hospitals in Arkansas for getting a patient started on bispecific therapy? For example, when you hear from a doctor that they want to get a patient started, what would be your typical workflow from that point?
Okay. Majority of these patients that we have are already our patients. So our physicians, are pretty well versed with them. The nursing staff, we pretty much know them. Majority of the time when they come to me and say, hey, I'm going to be starting this patient on such and such a drug. We put in the referral to the hospital that we're going to be referring them to. At one point, it was the University of Arkansas for Medical Science up in Little Rock. They are the ones who, had the huge myeloma institute and all that. So for the patients who were getting like the tech volley, those patients, we would send a referral to the myeloma institute, get them instituted up there working, with their nursing staff. The physicians at UAMF also keep in contact with our physicians as well. So we know exactly what's going on with our patients. And then making that transition back to our office is pretty easy with that type of drug because patients are already there. We know exactly what's gone on with the past 2 cycles of them getting that drug. And so we just transition them back, make them an appointment to get started on their cycle 3 drug. So those types of drugs aren't that difficult for us to set up. The CAR T ones can kind of be a little more difficult, especially if they're out of state. We've had a couple of those that have been out of state at the VA in Vanderbilt, and that we've had to work with to kind of get them back into our office and to resume care afterwards. And so doctors will come to us. We make sure that the nursing staff is educated over these drugs. I would set up the nursing education for them and do the REMS program and stuff for the office and get all that set up for them.
Quick question about when you're first getting a patient referred over to the hospital. Do you end up usually sending orders to the hospital, or will they often use their own order sets and then we just return to using ours once they transition back to our clinic?
No, we refer them for the tech volley, but they use their own order sets. And then when they transition back, we use ours.
Okay. Have you had any experience with using some of the bispecific therapies that you can give in clinic, but then may require a inpatient observation time after administration.
Yeah. A couple of months ago, we started a patient on Linsumio. So that was a different challenge because we kind of had to figure out how we were going to manage that. A lot of our patients are out in the rural areas of Arkansas, so 1.5 to 2 hours away from our office that they're having to drive in. So we kind of had to figure out, getting them into the hospital, how we were going to do this. So that's when I brought in Fran, who is our clinical nurse manager, and we kind of started discussing how we were going to handle this one patient. We got the medical scientific liaison involved with it. We had our drug reps involved with it from that point on as well. So we were able to get one of our local hospitals here to agree to let us admit patients for observation in their CCU unit for these types of drugs. And Dr. Divers played a big role in that with meeting with their executive boards and stuff to get that on the way so that we didn't have to send them up to Little Rock after they had their infusion here. So we are able to do it in Hot Springs at one of our local hospitals.
That sounds like definitely a big effort on communication between everybody in your clinic. And it's nice that you're able to offer that for your patients that are definitely more rural based and having to travel a long way. What are, we've talked about a few of them now already, but what are some more common challenges that you face when coordinating bispecific therapy between inpatient and outpatient settings, and how have you overcome some of those?
A lot of it is getting patients to understand that eventually you are going to be coming back here. There is a lot of patient education that goes on to it because we have to continue on and then still continue to monitor them for the possibility of the CRS or ICANS that some of them can cause. One of the other big ones is getting a lot of the information and stuff from the patients and stuff themselves and the hospital sometimes, getting all the records and stuff that we need.
Yeah, I could definitely see that being a challenge, especially with just the differences in electronic medical records. And, if you get a document that's scanned in, it might be harder to sift through an entire hospital visit for finding information you need. So,
right. Luckily, our medical records personnel have access to some of the records and stuff and the EMR systems. So that they can go in there and go ahead and get that information. It's just keeping in contact with the staff up there and then keeping in contact with the patient and the family to make sure that we get them back at the time that they need to be back here.
That makes sense. Yeah. Again, the common theme here is communication, whether it's, having those consistent contacts with the hospital or having that designated caregiver or the patient themselves that is a good communicator.
Yes.
In your experience, how has the relationship between your clinic and the hospital evolved over time, especially as more and more of these bispecific therapies are coming to market?
The one up in Little Rock that we deal with a lot all the time, and like I said, it's UAMS, and we have a really good working relationship with them, and we've always worked very closely with them as well. Now that we've had to kind of figure out how to take care of the ones here locally that do not have to have the hospital admission for their first couple of cycles of it, it took a couple of meetings, some education part for the staff and for the pharmacy there, to be able to get them to understand what we needed, how to take care of these patients. And Fran and Dr. Divers played a huge role in that, because they were going over there helping to educate the staff. I know Fran went and did the pharmacy and the nursing staff over there as well. And then, Dr. Divers spoke with the, physicians and stuff and the board over there to get them. So that working relationship, I think, is working out very well with that one specific hospital here locally. I think it's helped open up definitely some communication.
I feel like one concern I hear from a lot of providers through Aon is, when they refer a patient to a hospital to get started on therapy, that there's the fear that they may not want to come back to our local clinic to continue on their treatment. Is that something that you feel like you guys have been running into, or have you had any trouble with getting patients to return to Genesis?
No, actually, we've never had any problems with patients wanting to stay up there and not continue their treatment with us. They understand why we're having to send them up there to get them started. And they look forward to coming back and seeing their physician and their staff that they're used to. In fact, they're pretty anxious to get back to us. I have one right now that does not want to finish her second cycle at UAMS. And I'm like, no, you have to do that. And then you can come back to us. So I haven't had any patients say they don't want to come back.
That's really good to hear. I feel like that'll be really reassuring to a lot of doctors that are out there, especially in more like rural locations that they're having to send patients off to academic medical centers or local hospitals to get started on therapy. So thanks for that. My last question I have is important from a pharmacy standpoint, and that's about tocilizumab stock. So how does your clinic ensure that tocilizumab is available at the hospital when you have a patient getting started?
That was one of the educational things that Fran did talk to the pharmacy staff about, as well as Dr. Divers. They did agree to order the drug and have it on hand. And then our office also had it on hand for the patient that was here as well. So it was not an issue for them to be able to get that or to agree to them to do that.
That makes sense. Thanks for sharing all of that, Jennifer. That was really helpful. I think that that providers across Aon and outside will be able to really take something away from your experience that you've had getting patients coordinated with hospitals at the Genesis Clinic. So that concludes our episode for today. Thank you so much for listening to the RxConnect podcast. Be sure to visit our website at aoncology.com for more information and to access the transcript of this episode. And stay tuned for our next episode, where we will continue to explore the latest advancements in oncology pharmacy. Thanks again, Jennifer.
Thank you, Kathy.